invitation. It has been amazing and really great to see this morning kickoff. So I would have actually maybe done the presentations the other way around. So let's go back a little bit of what's been done so far with regards to this field. And this is my talk. So the two things I want to cover today is, just the role of incretins in obesity and liver disease. In liver disease, as well as the risk of HCC and risk reduction, so we'll talk about that. And then just to point you to the AASLD guidelines with Dr. Rinella as the author in 2023, as well as the update in 2025 for the latest guidance. Now, when we think about the natural history of MASLD, on the left is just death over time. So in this study, this is following 1,800 patients that are biopsy proven, followed for about a median of 4 years. On the left, what you can see, as expected, and as we know, that patients who are stage 3 or stage 4 fibrosis have a significant increased risk of death from any cause. And then on the right, if you can see, is from hepatic decompensation itself, again, stage 3 and stage 4. And why does that become important? The point being, the earlier we can intervene, the better, and hopefully we can dent the natural history of this. Now, when we think about sort of the two agents, the GLP-1, the GIP receptor agonist, as being FDA approved for the treatment of type 2 diabetes and being overweight and obesity, remember we're just talking about a small snapshot of all the treatment that is out there and will continue to happen, as was highlighted by Dr. Rinella in the previous talk. So keep that in context of, where would sort of, these agents now fit into a landscape that keeps changing. Weight loss, exercise, multiple agents coming out, managing comorbid diseases, statins, bariatric surgery. So how do we place its role in the context of everything else? So first, let's talk about its role in liver disease. And again, I'll highlight 3 or 4 agents. First one, liraglutide, and looking at NASH resolution. And here was a seminal study presented in Lancet now about 9 years ago. And let me walk you through 3 different aspects of this. Now, what you can see is, as compared to placebo, your weight change is pretty much in the first year. Once you have that, you see this period of stability. And then once treatment ends, which is after the second arrow, the weight actually increases. So yes, you have the benefit. Seems like the benefit is early. It's sustained. But once treatment is gone, then what do? And it goes up again. And you can see the same pattern for HbA1c on the right, and at the bottom left in terms of your transaminases as well as GGT. Semaglutide in stage 2 to 3 fibrosis, given for 72 weeks at 0.4 milligrams sub-Q daily. This was a New England study in 2021, and you saw some of the data from the phase 3 presented at the previous talk. And here what you see is that with the higher dose, which is the third column, again, you see the percentage of patients with resolution of NASH being higher as compared to placebo. And same thing in the panel B, where you see the same kind of effect in terms of improvement in liver fibrosis stage. But what you can see there is, look at the p-value. The difference was not significant. With the late breaker during AASLD, we saw that maybe with the upcoming manuscript, there would be a difference that we would be seeing in the phase 3 study. Similar patterns of liver test improvement, and what you can see is that this, as a surrogate for improvement in liver disease activity, is sustained through the 72 weeks. What about in biopsy-proven cirrhosis? So this was, again, a smaller study looking at once-weekly subcutaneous semaglutide in 71 patients, which, again, the dose escalation over the first 16 weeks. What you see is that even though numerically the patients that had improvement in liver fibrosis and no worsening of NASH was lower, as well as the resolution of NASH was higher, this was not a significant finding in this study. And you also did not see an improvement in MR elastography. Tirzepatide, the dual agonist, again, exciting data here, presented last year in the New England Journal of Medicine, once weekly administration in this patient group with about 60% diabetic, once again with the higher dose, seeing a difference as compared to placebo, both for the resolution of MASH as well as a decrease in fibrosis stage, but again, this was not significant. Now, we've talked about these agents, but the question is, why don't we put it in context with other things that are out there? So here's an example of orlistat, phentermine, naltrexone, liraglutide, semaglutide, and tirzepatide. And each of the columns represent the body weight reduction. So you have 5%, 10%, 15, 20, and 25. What you can see, if you look at the last two columns of semaglutide as well as tirzepatide, both of them sort of achieve that 5%, but getting to that 10% weight loss target, it's achieved more with tirzepatide. And that's sort of the theme, is that as you start adding agents, you're sort of getting an incremental improvement in the percent of weight loss. The question here remains is, how is this relative to surgery? Now, as I showed in one of the first slides, is that yes, you have improvement, and you have improvement that's sustained beyond 1 year, but once you get off these agents, then what? So that's the question I think we need to address as we continue with the chronic management of our patients for 20 years, 25 years, 30 years. What about diabetes status? This study just compared weight loss in different groups, no diabetes, pre-diabetics, type 2 diabetics, and overall. And the weight change is about the same across all this. So it seems like, in terms of the weight loss, it does not matter, and it's not contingent based on your diabetes status, that you're looking at about 10% to 12% weight loss. Now the landscape again has changed for the first approved medication in patients with stage 2-3 fibrosis. That is not the focus of this discussion, but here's some guidance of how to monitor patients who are started on this therapy who are stage 2 to 3 fibrosis. In our clinical practice, we're limiting this to patients that are stage 3 fibrosis. But the point I'm bringing out here is that even in this study, and this is from the AASLD guidance just released in 2025, is about 15% were already on GLP-1. So again, how does that role change as more and more agents come onto this market? This is not going to be the last one, as what's already highlighted. And hence the landscape instead may be a combination therapy based on the previous one, as well as the data that was presented here. Are we going towards combination therapy in stage 1 to 3 fibrosis? In this study, every patient was already on GLP-1, had been stable on it for about a year or so, and then were placed on a second agent. What you can see in the first figure is the number of patients who normalized liver fat was 88%. And on the right side, in terms of improvement in liver stiffness, that also improved more when you were on dual agents. And the difference in terms that was driving this was about an additional 1.2 kilograms of weight being lost more as compared to just being on a single agent. So again, the same theme is that you get some bang for your buck with the first agent, then incremental benefit as you add more. Let me pivot a little bit to thinking about risk of HCC. And what is the role of GLP-1 and sort of modulating your risk of developing liver cancer? So the treatment paradigm for prevention of HCC, as you can see, many things that we do for our patients have been associated with reducing your chances of liver cancer. And the question is, in this context of treatment of diabetes, treatment of obesity, weight loss, stopping alcohol, stopping smoking, genetic factors, trying medications, what is the role of sort of the GLP-1 or GIP in this context? Now, this study published in 2024 showed that as compared to patients that are on insulin, patients that are on GLP-1 have a lower incidence of liver cancer. And so the question is, should we be putting all of our patients on GLP-1? The answer is no, but I'll just show you some data on that. If you look at about four different studies that have looked at it, so each of the rows is a different study that has looked at sort of, retrospective data, because again, at this stage, we really don't have prospective data to really look at the incidence of HCC. The first study looking over in 1.6 diabetic patients in the United States using administrative data, GLP-1 versus insulin, HCC improved. Second study, same kind of finding. You had cirrhotic patients between 2019 and 2022, followed for 2-3 years. The outcome being HCC, even that decrease. When we broadened this to other countries, Sweden, Denmark, Norway, 4% being on semaglutide, again, compared to the non-insulin comparison group, there wasn't an change in HCC. And finally, GLP-1 compared to multiple. Yes, it was lower as compared to insulin, but not other agents. And here I'll sort of go into one of the studies in more detail. What I want to point out is two of where the arrows are pointing out. So what this is comparing is patients that were on GLP, but not on insulin, as compared to insulin. And as you can direct your eyes towards the right, what you can see is that the incidence of HCC here was lower. Similarly, even in the non-obese patients, which is the second orange arrow, what you can see is that GLP-1 versus insulin, the incidence of HCC was lower. So yes, it is, as compared to insulin, being on GLP-1 does decrease your risk of liver cancer development. However, the question is it just glycemic control, or is it truly that insulin may be associated with a high risk? So it can go both ways in retrospective data. Because if you look at other agents, an example here being metformin. So on the left, as compared to insulin, and here's looking at multiple cancers, including hepatocellular carcinoma. What you see in terms of the summary is on the left panel is that it is a superstar against insulin. But if you look on the right panel, as compared to another agent such as metformin, you see that the impact is about the same. And then finally, we talk about medications, but what about things that we should be doing? Like I bet everybody is the first panel, right? All have normal BMI, nobody drinks, no smoking, everybody sleeps 9 hours, everybody's on a Mediterranean diet. How many people are on it? Not me. Right? But that gives you the best bang for your buck, is that if we just do true lifestyle changes, you have about a 87% reduction in bad things happening. So that's sort of your reference standard. If you go really intense lifestyle modifications, that's 16%. If you do surgery, that's about 30%. So the question is, do these agents that we keep talking about and will continue to talk about do better than things that we should be doing on a regular basis besides surgery? So to sort of summarize, we do feel that GLP-1 likely will be the baseline for management of comorbid conditions until it gets an indication for MASH specifically. But until then, we seem like that could be the backbone of medical-based therapy. Second point is that the additional impact seen on weight loss with the dual agents or medications with alternative mechanisms, and I'm keeping it sort of loose-ended right now because you don't know what the landscape is going to be in a year or two, there will be an impact. My guess is about 1 to 2 kilograms more. Third, the impact on HCC reduction may be related to improved glycemic control rather than agent-specific. And then finally, the issues besides cost, which I did not mention on this, compliance, duration of therapy, as well as durability relative to surgery also needs to be seen. Thank you so much.
Thank you very much. Multidisciplinary, yes, management for the obesity and muscle, James Şimşek from Hacettepe University, Ankara. Nowadays, bariatric endoscopy is very popular. We are talking about this position. Thank you.
Yes, of course. Thank you very much for the presentation. I would like to thank you to the organization committee and our colleagues from the United States coming this long way. I think this is the next presentation, not mine. Sunumu değiştirebilir miyiz? So here's my presentation plan. I do not have any conflicts of interest. So I would like to start with rationale for endoscopic bariatrics. Obesity is a key in the muscle pathogenesis, and weight loss may not be the only strategy, but remains to be the key for us to manage muscle D. So why do we need bariatric endoscopy? I think there's a treatment gap between lifestyle pharmacotherapy and surgery regarding efficacy and adverse event durability and tolerability. And this gap can be filled with bariatric endoscopy. When you look, lifestyle interventions are very important. However, the data shows that only a quarter of muscle D patients can maintain 25%, more than 5% weight loss. So lifestyle interventions, although very effective, may not be enough. When you look at the incretin analogs, they are very effective, as you see, but there's a risk of weight regain when you discontinue them. And recent data shows that nearly half of those patients at first year discontinue the medication, and there's a risk of losing the benefits associated with it. Bariatric surgery, which we will discuss, is very effective for sure. However, a group of patients are not eligible, and out of those eligible patients, only 1 or 2% choose to undergo surgery. So 97–98% does not go. So this treatment gap can be filled by bariatric endoscopy, which has better long-term tolerability than surgery and seems to be more durable than medications. So the recent guidelines published by ASGE and ESGE mentions BMI over 27 plus comorbidity, or BMI over 30 as indications for bariatric endoscopic treatments. And bariatric endoscopy is not a new field. This is from 1982 from Lancet, showing the first endoscopic bariatric treatment, a plastic balloon, but over the 40 years, there has been tremendous progress in the field. The current spectrum of bariatric endoscopy, we can divide it into two. On the left, you can see gastric treatments, which are restrictive. That contains intragastric balloons, endoscopic gastric remodeling procedures, aspiration therapy. And on the right-hand side, you can see small bowel targeting metabolic therapies. I would like to start with intragastric balloons. We have different types of balloons. We have fluid-filled, gas-filled, more than one balloon, or swallowable balloons. But when you look, their mechanism remains the same. It's delayed solid gastric emptying. And when you look at their weight loss efficacy, while they're in 6 months or 12 months, the weight loss efficacy is between 5 to 10%. Fortunately, serious adverse events are low at 1%, but nearly 1/3 of those patients have pain and nausea and GERD while the balloon is in place. And those rare adverse events can happen. When you look at the liver parameters with the balloon, this is a meta-analysis with 19 studies. The liver volume is decreased, steatosis and biochemistry is improved, as well as anthropometric and metabolic parameters. And when you look at the muscle D patients, this meta-analysis of 10 studies over 500 patients shows improvement in liver enzymes, as well as metabolic markers and anthropometric parameters. And this study, published in 2021, includes 26 NAFLD patients with 6 months fluid-filled intragastric balloon. The patient's BMI were 35 median, liver stiffness is over 9.7. When you look, there was a weight reduction of around 14–15 kilograms, H1C reduction of nearly 1%. And when you look, liver stiffness is decreased from 13.3 to 11.3, around 2 points, and CAP score is decreased around 60 points. But there is a problem with intragastric balloons, like incretins. The data shows in 3 years, 2 years, 5 years, when you remove the balloon, there's a risk of weight regain with intragastric balloons, therefore the risk of losing the benefits associated with it. So this is what moved the endoscopists to endoscopic gastric remodeling. Those procedures are inspired by surgical procedures, mostly gastric plication. We use suturing devices. Here you see the overstitch device, and with those devices you can see we do mucosa to mucosa or serosa to serosa gastric tissue approximation. You can see the handle, and we control the suturing device at the tip of the endoscope with those handles. The procedure was first performed in 2011 by Dr. Thompson and House, and we still use the current technique. This is from one of my patients. You can see the stomach before the procedure. And you see the suturing device. We use the suturing device to suture around the greater curvature aspect of the stomach from anterior to posterior aspect, and then we cinch it. You can see how we narrow down the tissue, and this is the final look of the stomach in a sleeve configuration. There are different devices. This is another one we use, primary obesity surgery endoluminal post-procedure. This is a little bit different than the Apollo device. You can see on the right-hand side, there's serosa to serosa applications. This is especially beneficial in patients with advanced fibrosis because this serosa to serosa applications is better able to control the engorged vessels outside of the stomach due to portal hypertension. And this is, again, is from one of our patients from the United States. You can see we pull the tissue with a helix. We use an approximation device. We squeeze the tissue between the approximation device, and then we push the baskets. You can see there's bleeding, but when we squeeze the tissue, as the application is serosa to serosa, we can control the bleeding. This is very important for patients with increased portal hypertension. So you see the bleeding has stopped. So ESG's mechanism is similar to intragastric balloons. It seems we still have delayed solid phase gastric emptying. We also know that ghrelin levels are decreased with postprandial improvements in insulin sensitivity and glucose levels. And when you look at the weight loss efficacy of endoscopic sleeve, this meta-analysis shows 16% in 12 months and 20% in 24 months, which is over intragastric balloons for sure. And when you look at the adverse events rate, it's 2.2%, bleeding and leak being the most serious adverse events, and both below 1%. And maybe most importantly, the maintenance of ESG is successful. This is a prospective 5-year study from 260 patients from New York group. You can see 2 years weight loss is around 15%, and 5 years the weight loss is maintained at 15.9% in this population without any long-term side effects. And when you look at the liver data, this study ESG in NAFLD patients, 118 NAFLD patients, 2-year follow-up, BMI is 40, weight loss is achieved at 15.5 of total weight of 2 years, and you can see improvements in insulin resistance as well as steatosis index and fibrosis scores. And the study, 42 patients with NAFLD obesity, you see the poses used here because of the risk of bleeding with the extragastric vessels versus 22 lifestyle. Primary endpoints was CAP improvements with pose and hepatic steatosis, which were on the right-hand side, you can see significantly increased, as well as liver enzymes, steatosis, and fibrosis indexes. And this meta-analysis of 18 studies, 800 patients, also shows that improvement in fibrosis scores with ESG, as well as histological, biochemical, and metabolic parameters. This study published last year from the Brigham group. There were 20 patients with NAFLD and compensated advanced chronic liver disease. The baseline BMI of the patients was 40. The liver stiffness mean was 14.7. The study also performed US-guided PPG at the baseline and 6 months to assess the differences in the portal pressure. And after the procedure, you can see the decrease in median PPG levels from 5.4 to 1.8 millimeters. And 79% of patients have more than 20% reduction in portal pressure gradient. The liver stiffness was decreased to 7.1 from 15.5. And nearly 90% of patients has achieved more than 7% total body weight loss, and around 70% achieved more than 10% total body weight loss after endoscopic sleeve. And next, the same group retrospectively tested whether addition of incretins, GLP-1 analogs to ESG will further increase the benefits. This is 30 patients comparing endoscopic sleeve versus endoscopic sleeve plus GLP-1 analogs. The BMI was 40, liver stiffness was 14 in this population. You can see The addition of GLP-1 agonists on the left upper side further decreased from 51 to 35 to 54 to 19 the ALT levels. We can also see differences in NFS, PIP4 scores, and liver stiffness. When you combine ESG with GLP-1s, you can see the liver stiffness reduced by 50% compared to 40% with ESG. And ESG is also very successful to manage the comorbidities. The single standard 1,000 patient prospective study showed 14.7% total body weight loss with 100% remission of hypertension, 76% in diabetes, and 56% in dyslipidemia. And again, in this meta-analysis of ESG with comorbidities, 35 studies, more than 7,000 patients, show 1-year weight loss of 16% and 55% remission of diabetes, 62% hypertension, 56% dyslipidemia, and nearly 50% sleep apnea after endoscopic sleeve. And now, the FDA has approved ESG as a weight loss procedure. If so, World Gastroenterology Organization and NHS, ASG, ESG have guidelines or endorsements regarding endoscopic sleeve gastroplasty. And the technique is currently improving. This is a modification of endoscopic sleeve gastroplasty. Here we also add an antrum myotomy to further decrease the emptying of the stomach here. This is like a gastric palm procedure. We open an incision in the distal corpus. Then we open a tunnel through the antrum, but we do not touch the pylorus to preserve the gastric emptying. And after we finish the tunnel, you can see the circular muscle underneath. We do a full thickness myotomy to further decrease the emptying of the stomach. The initial results are very promising. The weight loss is increased to 5 to 10% more, and this will probably give more benefits regarding the liver as well. We also have small bowel therapies. The principal mechanism of those therapies is both decreasing the absorption from the proximal bowel, but also using the foregut-hindgut hypotheses and decreasing the anti-incretin factors and increasing incretin secretion. Duodenojejunal bypass liner is just a sleeve you see is placed in the duodenum bulbus and the proximal jejunum. And those small bowel therapies is more mediocre weight loss. As you see, this is 11.1 kilogram, but not percent. But they have better or as equal metabolic benefits. You can see the H1C decrease of 1.2%, which is close to ESG. However, when you look at their liver effects, they are not as impressive as endoscopic sleeve or intragastric balloons. This 32-patient study does not show any change in fibrosis markers, although AST and ALT levels were decreased. The second one is duodenal mucosal resurfacing, where we use a hot liquid filled balloon to ablate the duodenal mucosa. However, this also study published in Obesity Surgery 2021, 127 patients, there was a minimal weight loss and liver outcomes, decreased ALT and liver stiffness, but fibrosis did not change as well. So for the future, this is also another device developed by the Brigham team. They insert 2 magnets to proximal and distal small bowel and create a anastomosis bypass through endoscopic measures without requiring any surgery. This is currently in phase 3. And you can see the very wide and patent anastomosis on the left lower side. And also this is an endoluminal surgical robot, which is currently used in Brigham and Women's Hospital. And this robot has also capabilities, and in the very near future, it will be used to do endoscopic surgery, like endoscopic sleeve, but also endoscopic dissection, resection. Any types of endoscopic surgery can be performed with this robot. So for conclusions, I think at AASLD we have upcoming medications, but we still do need weight loss strategies. And I think from weight loss perspective, bariatric endoscopy fills a significant gap between pharmacotherapy and surgery. Endoscopic gastric interventions, primarily ESG, is effective, safe, and durable for weight loss in muscle D patients. Small bowel methods seem to be less effective. However, we do not have as much data as we have for gastric procedures. And of course, we should always stress multidisciplinary approach and individualized treatments for those patients. And I think the future belongs to robotic surgery, advanced imaging, and artificial intelligence. Thank you very much.
Thank you very much for your nice presentation. Next speaker, Hasan Altun. He is general surgeon from Istanbul, bariatric surgery management for the obesity and muscle.
Good morning. Thank you for the opportunity to talk here. I want to talk about bariatric surgery, the effect of bariatric surgery on the effect of bariatric surgery on obesity and MASH. I have no conflict of interest. The obesity is there's a global epidemic of overweight and obesity, and the World Health Organization called this as globesity. Obesity is a complex disease, you know, and it's a multifactorial disease, and it causes a lot of comorbidities. When you see the map, obesity is increasing in the world, and in United States and in Middle East countries, there are more than 40% of obesity. Also in Turkey, Turkey is the highest obesity prevalence in Europe, and obesity rate is 34 in Turkey. Just the numbers of obesity surgeries from United States, AASLD, American Society of Metabolic Bariatric Surgery. When you see here, the numbers of surgeries is increasing. In 2022, 300,000 surgeries were performed in the United States. After 2020, ECG, one of those gastric bypass and study procedures were also added to this table. In Turkey, we perform a lot of bariatric surgeries. In 2024, more than 100,000 patients underwent this surgery. These numbers also from ESMBC. The blue line shows sleeve gastrectomy, and the red line shows coronary gastric bypass, and the green line shows gastric banding. Gastric banding is decreasing, and the sleeve gastrectomy is increasing. And there is a decrease in 2020 during the COVID pandemic, and during the session, elective surgeries were stopped. When we look at the history of bariatric surgery, it started with the suturing the lips of Leon King. And after that, modern bariatric surgery started after 1950s. This is the jejunum bypass. In this pain, 1963 performed this operation, and he divided jejunum distal to trites to 50 centimeters and anastomosed it to transverse column. There was a very short, small bowel, but it caused a lot of problems. It has a good weight loss, but it results fatty stool, diarrhea, anal problems, and at the end, it caused hepatic cirrhosis and hepatic failure. And all these patients converted to jejunal ileal bypass. Jejunal ileal bypass also performed by Payne in 1969. It resulted good weight loss, less diarrhea, but there was a blind loop, very long blind loop. Due to this blind loop, anaerobic bacterial overgrowth occurred, and this called bypass enteritis. And it caused, due to the toxins, cirrhosis and hepatic failure. The mortality rate is very high, and after that, most patients died or converted to other procedures. Horizontal gastroplasty. Surgeons turned from malabsorption to restriction after some time. In 1970s, this surgery performed, and stomach stapled horizontally, and the surgeon left a small opening at the greater curvature, but the surgery caused a lot of problems like bezoar formation, regurgitation or reflux. Also, this surgery is abandoned. And some surgeons modified the surgery to reduce complications. Also, this surgery caused the same problems and was abandoned. Vertical banded gastroplasty, it's mostly performed in 1980s. There was a small pouch created with a vertical stapler, and the opening of the gastric outlet reinforced with a mesh. But after the surgery, the patient lost good weight after 1 year. But after 1 year, weight regain has occurred, and patients experience a lot of problems, like stable line dehiscence and outlet obstruction and perforation. Also, this surgery was abandoned after 1990s. There are three types of bariatric surgeries we perform today, and the restrictive procedures is adjustable gastric banding and laparoscopic sleeve gastrectomy. And also more restrictive and mildly malabsorptive procedures like Roux-en-Y gastric bypass, and mostly malabsorptive procedures like duodenal switch and mini gastric bypass procedures. These are the standard procedures. These procedures have long-term, like gastric banding, sleeve gastrectomy, Roux-en-Y bypass, and BPD. This type of surgeries has long-term results, and all these surgeries was endorsed by ESMBS. We are using ESMBS guideline to perform these surgeries. This adjustable gastric banding, this is a silicone band. It's placed upper part of the stomach, around the upper part of the stomach. It's a silicone band. It created a small pouch. But we used this band, but it was unsuccessful. It caused a lot of problems like slipping and migration. There was a port under the skin, and we can adjust the opening of the port with this opening of the band with this port. We can open or we can close the opening of the band. But the patients learned how to open up to close the band, and most patients use a syringe to adjust this, and when they go to the restaurant, they open the band, and after the restaurant, they close the band again. And it was unsuccessful. Some patients melted chocolate and drank it. Some patients blenderized solid foods and kebab and drank it. Also, there was first year was good, and after 1 year, most patients regain weight. And we abandoned this procedure, but it's still in use in some European countries and in United States. This is sleeve gastrectomy. This is the most performed operation in the world today. And in this surgery, about 70–80% of stomach is removed. Stomach volume is reduced to 100 cc, and this is a very successful procedure. It reduces ghrelin level. Operation time is very short, 45 minutes. It's a Roux-en-Y gastric bypass. It was very popular in 2000s. In the surgery, we create a small pouch, top of the stomach, and the small bowel is divided 50 centimeters distal to trites, and distal small intestine anastomosed this gastric pouch. And the biliopancreatic limb anastomosed 150 centimeters distal to gastric jejunostomy. It causes some restriction, also some malabsorption. Also, it's a powerful operation. Operation time, 1.5 hours. And this is the modification of gastric bypass surgery. In the surgery, we create a narrow, longer gastric pouch, and the jejunum, 200 centimeters distal to trites, is anastomosed to this pouch. It's more powerful compared to gastric bypass because there's more malabsorption in the surgery. Operation time is very short, 1 hour. This is the BPD. It's very powerful surgery. It's first performed by an Italian surgeon, Scapinaro. In the surgery, distal gastrectomy was performed, and the small intestine is cut halfway, and distal part is anastomosed to the stomach, and the biliopancreatic limb is anastomosed to the terminal ileum. 50 centimeter proximal to ileocecal valve. The food and the bile and pancreatic juice meet 50 centimeter proximal to the ileocecal valve. It's very powerful. It causes a lot of malabsorption, but operation time is very high, 3 hours. And some American surgeons modified this biliopancreatic diversion surgery to duodenal switch. They didn't perform distal gastrectomy, they performed salivary gastrectomy, and they cut the duodenum, and the small intestine is like cut halfway, and the distal part is anastomosed to duodenum, and the biliopancreatic limb is anastomosed to 100 centimeter proximal to ileocecal valve. Pleurus remain intact, and there's a longer common channel. Because of this, complication is lower compared to BPD. These are the standard procedures from gastric banding to BPD. Gastric banding is less invasive surgery, and BPD is more complex and more powerful surgery, more malabsorption. When we go from gastric banding to BPD, we have better weight loss, better resolution of comorbidities, but we have also more vitamin mineral deficiencies, more malabsorption, and more complications. There are also experimental surgeries. You can see also these patients. There's a transit bipartition surgery, there's a sleeve gastrectomy, and also there's a gastrojejunostomy. In the surgery, the surgeons claims that 1/3 goes to duodenum and 2/3 of the foods bypass the small intestine at the surgery. This is the modification of transit bipartition. In the surgery, there's a sleeve gastrectomy and loop gastrojejunostomy. Gastric plication surgery, it's very easy procedure. There's no need an extra instrument for that, and we will reduce the gastric volume with sutures. It's very good at 1 year, but after 1 year, there's high weight regain. After the surgery, also there's a high revisional rate. When you look at the mortality after bariatric surgery, this is a meta-analysis from British Journal of Surgery. When we look at all the procedures, the mortality is 0.08%. It's very, very low rate. This is for gastric band is very low also, but when we go to the more complex surgeries, mortality rises. For duodenal switch, it's 0.41% mortality. When we look at the comorbidity resolutions, this is the meta-analysis from Buchwald. The orange line shows band, and the blue line sleeve gastrectomy, and green line bypass, and purple line duodenal switch. When we look at the duodenal switch, the resolution rate is near the 100. It's a very successful operation. And also we will look at the sleeve gastrectomy, comorbidity resolutions higher than 60 in the long term. This is the study from Cleveland Clinic Stampede trial. It compares bariatric surgery and intensive medical therapy for diabetes, 5-year outcomes. When they compare these 3 techniques, glycated hemoglobin level decrease is very good after bariatric surgeries compared to medical therapy, intensive medical therapy. And when we look at the changes in BMI, also bariatric surgeries are very successful compared to medical therapy, and bypass is more powerful in BMI changes compared to sleeve gastrectomy. Also, this is a meta-analysis from Wilson, and there's a comparison of 32 studies, and they compared obese patients that underwent surgery and obese patients treated with medical therapy. Obese patients underwent low-risk surgery have low risk of cancer. Also low risk of cancer-related mortality. Also, these patients, obese patients underwent bariatric surgery, has lower risk of hepatocellular carcinoma. There's another study from France. This study analyzed the effect of bariatric surgery in obese patients with MASH. 180 severely obese patients and higher than 40 BMI with biopsy-proven MASH underwent laparoscopic bariatric surgery. and liver biopsies were performed 1 and 5 years later. And this study showed that resolution of MASH without worsening of fibrosis in 84% of patients at 5 years. Also, in 70% of cases, there was a regression of fibrosis. Also, I want to present our cases. We performed in 12 years 2,800 cases. 70% of cases are sleeve gastrectomy, Roux-en-Y gastric bypass, OAGP, revisional surgeries, and robotic surgeries and seals. Mean BMI was 42.1. Comorbidities, mostly hyperlipidemia, 34, hypertension, diabetes, and obstructive sleep apnea. When we look at the total body weight loss, percentage of total body weight loss at 10 years, at 1 year, it's maximum 36%, and after that, a steady decline, but at 10 years, 33% total body weight loss. When we look at the resolution of comorbidity, it is comparable to other studies in the literature. Hyperlipidemia 61, hypertension 60, and diabetes 57. When we look at the morbidity and mortality, we have only one mortality. Mortality rate is 0.03%. There's only 3 leakages, 0.1%, 16 bleeding, and we have no pulmonary embolism. Bariatric surgeons and plastic surgeons like to show before-after pictures of the patients, but I want to show you before-after pictures of the liver after surgery. The first patient, 45 years old female, BMI 56. She underwent laparoscopic sleeve gastrectomy. She has a lot of comorbidities. Liver function tests were normal. 2 years later, the patient lost 39 kilograms, and due to gallstone, the patient underwent laparoscopic cholecystectomy. When we look at the liver, this is in sleeve gastrectomy, very fatty, yellowish, and the edges of liver blunt. And this is 2 years later. This is the comparison of two liver. And the second patient, 39 years old male, BMI 60. This patient underwent laparoscopic sleeve gastrectomy. Only ELT was 68. 18 months later, lost 66 kilograms, and she underwent laparoscopic cholecystectomy again. And this is the liver, fatty liver of the patient. Under the liver, you can see the stomach. And this is the 18 months later, and you can see hydropic gallbladder. This is the difference. Also look at the distance between diaphragm and the liver. There's a very huge difference between the two pictures. And third patient, 45 years old male patient, BMI 44, ELT 70, other values were normal. He underwent laparoscopic sleeve gastrectomy. 7 years later, she lost almost 50 kilograms, and she underwent laparoscopic cholecystectomy. This is the short video of the patient. We will use Nettinson catheter to lift the liver, and I want to show you the caudate lobe. This is the caudate lobe near the stomach, very big caudate lobe. This is the liver 7 years later. You can see the gallbladder and the gallstones in the gallbladder. This is the fourth patient. We operated this patient 2 days ago. His BMI 38, but he's not severe obese, but he has a lot of comorbidities, type 2 diabetes, hypertension, hyperlipidemia. His triglyceride level more than 1,000 1 month ago, and she received some medications for that, also obstructive sleep apnea. EST level 107, ELT 236, ELP and GGT were normal. People scan revealed CAP score 289, and the stiffness score was 8.8 kilopascal. This is the short video of the patient. Very fat liver, and if you see the light reflection, there's a very irregularities on the surface of the liver. very big liver. This is the last slide. This is the left lobe, and this is the right lobe of the liver. As a conclusion, morbid obesity is a chronic disease, and bariatric surgery is very effective for weight loss and for resolution of comorbidities. But we operate only 1% of obese patients, and we need novel therapies to reduce obesity rates and for the therapy of MASH. Thank you for listening.
Thank you very much. Great presentation, and also thank you very much for your experience. We will take the question at the end of the session. Now, the AASLD cases were presented by Gupse and also Çağlayan. Gupse, microphone is for you. During the presentation, Gupse probably asked a question for the audience and listening guests.
Okay. Thank you for the opportunity. I will present a case from a real-life case. I have nothing to disclose. Our case is a 37-year-old female housewife referred to endocrinology due to class 3 obesity, type 2 diabetes, and post-thyroidectomy hypothyroidism in 2017. On physical exam, her height was 150, weight 180 kilogram, BMI was 52.4, and in her medical history, she had rheumatic heart disease, mitral valvuloplasty, asthma, thyroidectomy, type 2 diabetes, obstructive sleep apnea, and her medications were aspirin, diltiazem, spironolactone, salbutamol, beclomethasone, metformin, and levothyroxine. She never used alcohol, and she was a non-smoker. In her lab results, her AST was 58, ALT 52, FIB4 was 1.07, NAFLD fibrosis score was 2.943, A1C was 6.3%, triglyceride was 304, HDL was 30. In her abdominal ultrasonography, the liver was enlarged and increased echogenicity compatible with grade 3 hepatosteatosis. Portal vein was dilated. She had splenomegaly. What should we do next? What is the next step for this patient?
Okay, thank you very much. Gupse, could you go back the 2 slides? The question is, the patient has 1.0754 score, but NAFLD fibrosis score is 2.9. There is a huge difference. Mary, would you like to comment this?
Major limitation of FIB4 is in the context of diabetes because the prevalence of advanced fibrosis is really high. So the negative predictive value is much, much lower. So that's why I think the FIB4 is underscoring. Although actually looking at the AST to ALT ratio, I wonder if the patient actually doesn't have more advanced disease despite the normal platelet count. So I don't know if anybody else has comments on that. But.
Okay. Samet Asrani, would you like to comment?
Same question that, so one thing we often see is, in our patients, we see the splenomegaly, but still that does not always mean advanced fibrosis in certain cases. So, and FIB4 is also reassuring. So here I would still go for a second line test. With the high BMI, ultrasound-based elastography may not be reliable. And so one thing we've done is, MR elastography versus a biopsy.
Okay, thank you. Any more comments?
She was advised to follow a low-calorie diet and engage in regular exercise. And she was prescribed Orlistat, 120 milligram. In 2018, she was referred to hepatology. She had a BMI of 55.1. FIB4 was again 0.74. And later, exenatide was added to her treatment. A1C was 6.5. Again, BMI was 55.1. And 2 months later, her A1C increased to 7.7, and vildagliptin and dapagliflozin was added to her treatment. And at the end of 2019, her BMI went down to 48. FIB4 was again 0.61. For 3 years, she was lost to follow-up. She came back at 2022 while she was 42 years old. Her BMI was 50.6, A1C was 7.3, CCH level was 6.12, her FIB4 was 0.89, NAFLD fibrosis score was 2.533, and this is her first transient elastography. Her CAP score was 400, her stiffness was 21 kilopascal with the X large probe. Her FAST score was 0.87, it's high risk for MASH. At this time, she was taking exenatide, metformin, empagliflozin, levothyroxine, and warfarin. And how should we assess liver fibrosis and steatosis in this patient with class 3 obesity?
So one of the limitations of VCTE in the setting of that much obesity is that it's going to overestimate portal pressure. So in a non-obese person, you might say that's consistent with clinically significant portal hypertension. And it may be in this patient too, but in the setting of obesity, that is not as accurate. So there's a paper by Juan Abrales looking at it's called Anticipate NASH, and it basically calculates the likelihood of clinically significant portal hypertension and demonstrates that it's a bit lower, but so we can, I'm looking forward to see what else you find on the patient.
Any more comments? At admission, her BMI was 53. Right now it's 50. Would you recommend the endoscopic or surgical treatment? Yes, Fulya.
I need to do the surgery consultation because I think she has the severe fibrosis. So we have to think before she has cirrhosis, I think.
Okay. Would you recommend for her endoscopy treatment, JAM? And after JAM, Hassan, what would you do?
So this patient has a BMI over 40. In fact, endoscopic sleeve does not have an upper BMI limit, so it's still an option. But when you look at the weight loss we need in this patient, I think it should first go to surgery to achieve that amount of weight loss. If the patient is not fit for surgery, endoscopic options would definitely be an option for this patient.
Hassan, as a surgeon?
The risk-benefit ratio is important for these patients. If the anesthesia risk is very high, then endoscopic therapy may be more appropriate, and the risk for anesthesia is low, then this patient undergo bariatric surgery because his BMI is very high. After the 40, generally the other therapies were unsuccessful mostly.
Okay. Yes, she has several comorbidities. I understand your concern. Ray, would you like to say something?
I wasn't going to, but I can. I mean, this is tough. Like, she's 39.
42?
Right now, 42.
Right. So it's a young lady with humongous BMI, diabetes, and body is suffering. And it doesn't work in everybody, but in my practice, when patients realize that they start to have end organ damage from their obesity and have a really heart-to-heart conversation that you really need to work on your health. Some people make a significant effort to get healthier. So I'm not making any judgment, but is there a system to help these patients achieve realistic weight loss through multidisciplinary care, lifestyle modification? I mean, I think the fundamental change that needs to occur in the brain, not necessarily in the GI tract.
Thank you. Any more comments? Please keep continue.
After this transient elastography, she had an EGD and there were no varices. On MRI, there was no suggestion of portal hypertension, and the patient was referred to bariatric surgery but was denied due to high surgical risk. And 1 month later, she had a pneumonia and she had admitted to ICU. At the end of the year, while she had a BMI, again, 50.7, she had a sleeve gastrectomy. 3 months later, she lost 30 kilograms. Her BMI went down to 37.3, A1C 4.9. She stopped all anti-diabetic medications. And her CAP score went down to 291, stiffness 11.6. At the end of the year, the first year of sleeve gastrectomy, she had a BMI of 35.1, CAP 272, stiffness 10.4. Again, for 1 year, she lost the follow-up. She came back last month, sleeve gastrectomy, in the second year of the sleeve gastrectomy. She's now 45 years old. She has a BMI 39.6. She gained 10 kilograms. Her FIB4 is again 0.98. Knuckle fibrosis score is 1.983. A1C is 5.2. Her CAP score is now 384. Stiffness is 8.6. FAST score is low. And her current medications are levothyroxine, warfarin, metoprolol, salbutamol, and atorvastatin. She has an ejection fraction of 60%. She has a mild pulmonary arterial pressure, and she has a stage 2 kidney injury. In summary, she has class 2 obesity, hypothyroidism, rheumatic heart disease, hypertension, asthma, endothelitis, dyslipidemia, and stage 2 kidney injury. She has 3 cardiometabolic risk factors. Her CAP is 384, stiffness is 8.6, knuckle fibrosis score is ruled in as advanced fibrosis, and FAST score is low. What should we do next, and which medication should I choose for this patient? Resmetirom, semaglutide, survodutide, or tirzepatide?
Okay. Mary?
Okay, thank you. So I would probably, in this person would benefit from a GLP-1, so tirzepatide or semaglutide. Servo, we don't really have approval for this, but resmetirom would be another important option as well. The diabetes is under good control, so you could make an argument to just give resmetirom. It's an oral therapy, but I think a GLP-1 would also be reasonable and effective.
Samit?
Yeah, agreed. I think GLP-1 or the dual, either one is fine.
Fulya?
In addition, I think she has to have a psychiatric consultation, because although she has a lot of disease and surgery in the past, she is still gaining weight. So maybe she has eating disorder or psychologic disorder for the much more eating. So I think she has to have a psychiatric consultation.
Thank
Also
Okay.
with semaglutide.
you. Cem?
As this patient has already undergone surgery, but in the case of regain after sleeve gastrectomy, we still have endoscopic revision procedures where we can have 10 to 15% weight loss. So it can also be another alternative to medications in this patient population.
Okay. Ray?
I assume a liver biopsy was not done at the time of surgery?
No, unfortunately not. Yeah.
That's so frustrating. We ask surgeons to do that and then they always forget.
Levent?
It's important to understand what's wrong with treatment. So, as said, she had lots of diseases and she had lots of complications due to obesity. She had pneumonia and she had an ICU visit and she had she was in really bad situations, and then she's decided to have the surgery. And before that, the surgery, because of the risks of the surgery, she couldn't have the surgery at first. So she's in a very bad condition. With the surgery, she lost weight. Her diabetes situation and the other chronic diseases went well with the surgery, but beside this, she gained weight. So what's the reason she's gaining weight? We have to look for it. Sometimes it's not a psychiatric disorder. Sometimes she got a reflux because of the surgery. Because of the reflux, she's eating too much. Sometimes this happens as well. So we have to go through the eating habits with dietitian and also psychologists, psychotherapy as well. And at this site, at this point in Turkey, semaglutide is available. With going through her eating habits, semaglutide can be a good choice at this point. But we have to understand what's wrong with this patient. Sometimes she has a real bad reflux. That can be the reason of eating habits after sleeve gastrectomy. If we have a hiatal hernia or some reflux problem due to surgery, she can have a revision surgery that can go ease reflux and also that can help with losing weight. So we have to go through the reason why she's gaining weight.
Okay. Thank you.
If we talk about the medication, why the patient is going to the surgery? Which one prefer before the metabolic syndrome for the surgery? Why not gastric bypass? Why sleeve gastrectomy? You know, 5 years later, again, obesity, more than before the other successful, was gastric bypass, not sleeve gastrectomy.
Yeah.
Hasan, would you like to comment this? Yeah.
Most patients, we prefer sleeve gastrectomy. It's a simple operation, and it takes its anesthesia risk is very low for this procedure. And most of the patients, about 85% of patients, not regain weight. And for gastric bypass is a complex procedure, and after the surgery, the patient lose good weight, but it's a lot of problems like dumping syndrome and hypoglycemia. We prefer gastric bypass for patients only with gastric reflux or the patient have a lot of comorbidities, then we select gastric bypass surgery.
Can I comment?
Samit, Did you? No, no. Mary?
I think you're waiting, but I can. So I actually, my initial thought was also, why wouldn't you do a bypass in this patient? Because the BMI was like 52, and the durability is going to be better, albeit it's durable for many with sleeve gastrectomy, and because of the numerous comorbidities she had. So that's, I think, part of it. And I think it can stretch too, right? I mean, you can have stretching over time too with the sleeve. But in any case, there was another comment over
Levent,
there.
last word? Yeah, last comment.
Pre-surgical liver stiffness was very high. Even we know that it can be a
53.
The pre-surgical liver stiffness measurement was over 20. So we know that it can be exaggerated by the obesity, but with those scores, I think sleeve gastrectomy, and with the comorbidities she had, I think sleeve gastrectomy is a safe choice for this patient. I would recommend sleeve gastrectomy compared to gastric bypass surgery.
Thank you, thank you. There is a time limitation. Thank you very much, Gupse, for your presentation, and thank you very much for your kind contribution. Next presenter is Çağlayan. He's going to be present the muscle patient.
Dear Chairman and dear colleagues, I would like to present my case. I work in Rize, northeast part of Turkey. My case is 59 years old female. She's housewife, lives in Rize. She was referred for an iron deficiency anemia, actually, to our gastroenterology outpatient clinic, and she is postmenopausal. Her past medical history, long-standing type 2 diabetes, hypertension and hyperlipidemia was added later. She has the fatty liver since 2009, and she was operated for the nodules, her thyroid, total thyroidectomy. And her family history, nothing remarkable, no history of cirrhosis. Her medications, levothyroxine, DPP-4, and metformin. She takes statins as rosuvastatin, beta blocker, and angiotensin receptor blockers with thiazides. Her physical examination, her height 161, weight 86 kilograms, BMI was 33.2. She had class 1 obesity. Her waist circumference 107 centimeters. She has abdominal obesity, and she smokes 2-3 cigarettes per day, last 5 to 6 years. She doesn't use alcohol. Physical examination, scars for thyroidectomy, second tax on the neck, and onychomycosis, other, nothing remarkable. Her laboratory findings is consistent with anemia, and especially for iron deficiency anemia. Her AST levels 21/18, ALP GGT was normal, cholesterol levels, she uses statin, LDL 71, HDL 50, HbA1c is 7.8, thyroid functions normal, within normal range, vitamin D deficiency, and her FIB4 score 1.102, and NAFLD fibrosis score -1. We can negative viral serology and autoimmune serology. What would you do in next step for this patient?
Thank you, Çağlayan. 59 years old, female obese patient with comorbidities. Her family history, no liver disease and no cirrhosis. Is that really important? Mary, what do you think? The family history.
Yeah, so family history is very important. If you have cirrhosis in your first degree relative, the risk of having advanced fibrosis is about 19%. So that's pretty high compared to the general population, at least in the US, where it's about 1%. So almost 20 times the risk if you have a first-degree relative with cirrhosis from metabolic liver disease. So it's very important. It's also important for the risk of other diseases, such as autoimmune disease, if there's rheumatologic history in the family as well.
So what's the next summit? Next step?
I think in this page you have time to figure things out. I mean, this is the first time she's seeing.
In gastroenterology outpatient, first time?
Yeah, first time you're seeing this patient. FIB4 is less than 1.3. Platelets are preserved. AST and ALT are okay. So, I mean, I would, based on, I would start off with the trial of diet first, and really, according to, go for that first before thinking of medications.
Okay. Any more comments? Keep going, please.
Okay. Her FIB4 history with the electronic health records, it's mainly on below the 1.3. With 2 occasions, upper this limit becomes intermediate range. Her abdominal ultrasonography, liver size enlarged with grade 2 hepatosteatosis, no focal lesion, spleen was normal, and portal and hepatic system reported as normal. And patient with diagnosed muscle with 5 cardiometabolic criteria present and also evidence of cirrhosis. This is from our TASL patient guidance. If we detect enough of patients, we calculate the FIB4. It's suggested to calculate FIB4. And if the FIB4 is below 130, no need for referral, lifestyle change, and reassess with FIB4 with annually. This is from the AASLD patient's guidance. If the FIB4 below the 130, if type 2 patients, every 1 to 3 years reassessment is suggested. If diabetes is not present or less than 2 metabolic risk factors, it should be evaluated with 2 to 3 years. This is the AASL's suggestions, but the AASL suggests if the patient has same actually 1 to 3 years with duration. But we have imaging facility in our facility. We did fibroscan in our fibroscan unit. Her CAP score was 303 and 14.5 liver stiffness measurement, and her FAST score 0.65. Agile-3 score is extremely high, as around near to 0.9, and her ELF score also is a little bit high.
Okay, yes, Mary. What do you think the result of the elastography, fibroscan?
So before you showed that, I was going to comment that I know that not only our guidance, but also AASL and yours sticks to the less than 1.3, but when we were writing it, we had a discussion about whether patients with diabetes actually should just have secondary testing no matter what. And there was pushback to that because you would be doing a fair amount of unnecessary tests. But I would argue that if you have a fibroscan in your office or you have access that's affordable to secondary testing, I personally, in diabetic patients, will always do that because I know that the predictive value of FIB4 is not very good, and the cutoff should actually be 1. And in the future, I think we're going to be seeing a cutoff of 1 for diabetes for that reason. But this is not very surprising. The other small clue from your study, from your patient, is that even though the AST to ALT ratio or the levels were low, the AST is still higher than the ALT, and that to me is a little bit of a clue. Almost always though, with advanced fibrosis, your AST is going to be higher than 20, and it was just barely, it was 21. So I would have done a secondary test straight away on this patient, and all of this tells you that they have significant fibrosis.
Thank you. Any more comments?
So I may be totally wrong, but this I would say would be not a reliable study for me. You have 10 kPa, you have 17 kPa, and you have a large variation in that, and you've had FIB4 that's been consistently low, and platelets are okay. So that would be my thought. I'm not sure.
Thank you. Jalayan, go ahead, please.
After these two inconsistent findings with radiology and blood-based test, we discussed the patient, what would be next step, and we offered her to liver biopsy. She agreed, and this is her liver biopsy results with NAS score 5, fibrosis stage 3 with bridging fibrosis. And the patient asked us what about the treatment options for her and what is the treatment options for her.
Okay, go back to this slide. Yeah. Fibrous conditions cap 303, but NAS score on liver biopsy 5, only 5. 5 of the 8. What do you think this correlation, Mary?
So a NAS score of 5 is pretty high, actually. It's pretty uncommon to see a higher NAS score, so that's pretty high. And you're also seeing that sort of supported by the FAST, even though it's 0.65 instead of 0.67, that goes along with that, and so does the ELF score, which is pretty predictive in this context. So, I mean, I think that's a high score. I think it correlates pretty well.
So what do you think the next step?
So I can't remember, the patient's not on a GLP-1. I would probably use a GLP-1. The patient still has obesity, or you could also use resmetirom because it's not advanced obesity. I think it was class 1 obesity, right?
Class 1.
Yeah. So you could do, if you have access to that, you could do either of those as well in this case. And of course, diet, always, a diet and exercise, always. Yeah.
Any different comment, any more? Yes. Hassan?
According to ASMBS guideline, if the patient has a BMI on between 35 and the non-surgical therapy are unsuccessful, then these patients also can undergo the surgery.
Okay. So, Jalayan, what did you do?
We discussed with the patient the options. Actually, she had multiple failure on lifestyle medication attempts, and in Turkey, currently not approved for treatment for MASH. GLP-1, other than exenatide, there is a reimbursement problems, and also the semaglutide not approved for obesity in Turkey, just in diabetic indication. We have liraglutide, this indication, and we suggested her to enroll in the ongoing clinical trials. She accepted this, and she is currently on efinopegdutide or placebo arm. We don't know, but her BMI was decreased to 29.8. Thank you.
Okay. Well, thank you very much for your great presentation. I thank the all presenters for your very great presentation. I thank you also for your kind contribution. Lunch will be served on the upper floor, and bon appetit. See you after the. Oh, okay.
A small contribution.
Please.
Thanks to the all speakers. Last year, new techniques may be new, but it's old, I think. The most problem in our routine practice, before transplantation, waiting list, obesity, and portal hypertensive patients, cirrhotic patients, I think it's more problem for us because all of these techniques has some adverse events and really has high risk. Endoband gastroplasty. Also, we can use this technique in cirrhotic portal hypertensive patients. Last year in obesity surgery published small limited cases. Maybe we think about this.
Thank you very much for your great comments. Thank you.